So, good morning, everybody. A very warm welcome to all of you from Apollo Hospital, Indore. And I'm joined in my cath lab. I'm supported by Dr. Roshan Rao and my team, Arun, who scrubbed with me, Hemant and Sanjay on the table, Mr. Kayur and Mr. Raj on the IVUS and the OCT, and Dr. Vikas Gupta, who's my cardiac anesthetist, Dr. Ashwini, who's supporting me for the device, and Prem, who's my anesthesia technician. So very warm welcome to all of you. Can I have the slides, please? And special thanks to Dr. Srinivas for inviting me, and welcome to Dr. Ramesh Tagubati. May I see the slides, please? I can't see the slides. So, can you hear me?
Yes.
Can you hear me?
Yes, we can.
There.
Yeah, we can also see your slides, Dr. Sarita Rao.
Okay, you can see my slide? Okay. Can we go to the next slide, please? Somebody switch the slide. Can somebody move the slides, please? Technical support?
Yeah, I think they're figuring it out to go to slideshow. Yeah.
Okay. So just play the slides of the presentation, please. Can you switch this? Can you go directly? Tell them to go directly to the slide about the patient. Technical support, can you go directly? Yes. So this is a 50-year-old male patient. He's presented with complaint of chest pain and dyspnea on exertion class 3 and vertigo since last 1 week. Now he was admitted in an outside hospital. He's diabetic. He was diagnosed as coronary artery disease, old inferior wall myocardial infarction, and he was managed with medical therapy, antiplatelet statins, and other supportive treatment. Now his echo, which was done outside, showed a mild MR, mild to moderate PR, PA pressure was about 40, no LV clots, mild RV systolic dysfunction, and a very severe LV systolic dysfunction. His ejection fraction, which was reported outside, was 5 to 10%. Next slide, please. Now, this was his angiogram, which was done on 6/7/22 at another hospital. It revealed coronary artery disease with a left main ostial 70% stenosis. His LAD had a mid 80% lesion, distal 50%. The circumflex had a proximal 70% stenosis involving the origin of the OM1. OM2 was also 80%. Now, the RCA had a proximal 100% occlusion. Now, he was advised for a bypass surgery. Now, in view of his tight left main with a critical triple vessel disease with severe LV dysfunction, we confirmed his ejection fraction at our center. It was to the tune of 5 to 10%. The surgery was extremely high risk, and it was refused by the attendants and prognosticated for by the cardiac surgeon as well. Next, please. So let me show you the angiogram now. Can you play the angiogram? Hemant, can you see the angiogram now?
Not yet, Dr. Sarita Rao.
Okay. Can somebody play the screen now? Can somebody play the angiogram screen?
Yeah, we can see the angio.
Yes. So we took a repeat shoot of his angiogram just now. This is his angiogram. You can see the tight left main stenosis. You can see the lesion in the circumflex vessel. Next, please. He also has a distal LAD disease. Next, please. You can see the tight left main, the circumflex, the LAD. This is an RCA shoot. Next, please. Can you show the RCA shoot? This was his RCA is 100% occluded. Now, the question which lies between us right now is how do we approach? First, this patient's ejection fraction is only about 5-10%. So question number one, do we take any kind of a support, mechanical support? Question number two, he has a left main, circumflex, RCA, LAD. How do we approach? Do we first approach the LAD lesion, fix that? Then we go ahead, approach the circumflex lesion and the LAD lesion, subsequently followed by right. Or would you like me to fix the right first and then go to the left system? I would like to have the opinions of the board.
Yeah. Thank you. I think that's a great segue. Dr. Sandeep Bansal is here. What do you think do you think, yeah, go ahead.
We generally would do the tougher lesion first. So one would approach the right coronary first. This is a surgical reject, but by and large, if we are approaching a patient who's not been decided or has been taken up for PCI itself, we would first approach the right coronary artery, and if you can't do that, then send the patient for CABG. But here, since it has already been refused, I think even approaching the left system may be a good option.
Okay, very good, thank you. Do you need any further information before we go on to, or are you happy with the information, or do you want any more further information to decide?
So,
is there any viability information? You managed to get any viability information?
So we didn't subject this patient to any viability testing, but on the echocardiogram, the thickness of his left ventricle was preserved. And this patient is having resting angina. So we assume that the territory is viable. What would you say?
Yeah, so that's Dr. Sandeep Bansal and I were just chatting while you were presenting. With an ejection fraction of 5 to 10% and having thick muscle, those two are not going hand in hand.
Angiographically, LVEF looks reasonably better rather than 5 to 10%. If looks.
The motion on the X-ray machine that you see, that
like
obviously, yes, that's
15%
true.
or something.
Yeah. So probably it is a bit better. And so the question about viability, just for the audience, and Dr. Sarita Rao said very eloquently that whether there is viability or not, there is still outcomes are slightly better with the revascularization of it than without. So that said, we do normally check in our institution its viability. The other question is that how comfortable are you to take on this patient knowing that this is a surgical rejection and is something that you have to be very well prepared for? I don't think that everyone should say that, oh, I saw one case today, so let me go ahead and do it. This patient can die on the table. Are you willing to take the responsibility for that? Or are you willing to say that it's okay, that you can manage medically? So these two are something that you probably have to think about. You know. Any other comments? Yeah, it's on.
And some sort of circulatory support, definitely, even with a EF of 20 to 30%, 25 to 30%. If not impel, at least IABP to go ahead, because there is a left main lesion which needs to be tackled.
You said IABP?
Yeah. At least IABP, some sort of circulatory support.
Mechanical circulatory support,
yes.
yeah. So Dr. Sarita Rao, you heard that, so questions are viability, and is the EF really 10% with the thick ventricle? Then what sort of mechanical circulatory support you're planning to do? And not to go for RCA, CT, or PCI as the first one, you know, right? So please tell us your approach. What are you planning? Can't hear you, Dr. Sarita Rao.
Technical support, can you please?
Yeah, we
fix
can
my
hear you now.
line?
We can hear you now.
Okay. So thank you for all the lovely comments, and we really appreciate it. Now, the ejection fraction looks a little better because right now he's on a 10 mics dose of adrenaline. Second is whether I'm willing to take the risk. This patient actually has no other choice. You see, he's a surgical reject. He's been to several surgeons. The risk factor was too high for him. He's having resting angina. Does he really have any other choice? Does he really have any other choice with this angiogram, except that a cardiologist like you would take him up and relieve him. So yes, I'm willing to take the risk because this patient has no other choice. The third thing is that, yes, maybe we should have done viability testing, but I believe that the presence of angina, that the presence of preserved thickness shows me that this patient's myocardium is viable. And the third point which we raised, this patient requires a mechanical circulatory support. So we had two options as elucidated by the panel. We had the option of taking an IABP and we had the option of doing an impeller support. Now, in view of the fact that this is an extremely high-risk case, we are going live, and I really would not want anything to happen to this patient, we decided to go in with an impeller support. So you can see, I already have the impeller in. Now we'll show you what we did till right now. Our approach, now the RCA is a CTO. We didn't know how much time it would take, how much dye it would take. So we decided to go in with the left system first. Our approach was to fix the left system first and then fix the right. Next, please. So this is, we've taken a PPI. We're trying to go very safe, taken in a temporary pacemaker. Subsequently, we are taking in the impeller. This is an impeller 2.5. Next, please. We've gone ahead, wired the circumflex, ballooned the OM. Next, please. Please go ahead. Next, next. Just go next. We also ballooned the branch. Plan was to go with a single strength strategy there. Next, please. So the OM lesion was at actually a trifurcation. We ballooned the other two vessels. Next, please. So this is post. Next, please. Went into the middle vessel. We ballooned that as well. Next, please. And then we've taken the stented. This is a 2.5 38. And this is post-stenting. So this is the point at which we left the circumflex alone. All the three branches were flowing. Next, please. We post-dilated it. Next, please. And this was a final shot of circumflex. We were reasonably happy with the results of the circumflex per se. Next, please. Then we went ahead, went into the LAD. Now, this is an IVUS run which we are taking in the LAD to left main. Can somebody focus on the IVUS screen and show the IVUS finding? Keyur? And Sanjay, can you tell? So, can you see the IVUS?
Yes, we can, yes.
Yeah. So we have a vessel size of 3 at the LAD, ostium. We are planning to stent from left main to LAD. We also, at this point when we were taking our IVUS run, we had some decompensation. So, and it's basically fibrous fatty tissue. Can you go to the next shot, please? So we went ahead and we fixed the distal LAD lesion. Next, please. Next, please. Next. Yeah, somebody can show the angiogram on the screen. Remove the IVUS and this we fixed. Next, please. The little indentation in the middle. We went ahead. Next, please. Post-dilated it. Next. Next. So, at this point, we fixed the distal lesion, and this is where we are at now.
So that's
So,
Dr. Sarita Rao, I think your impeller is a little bit deep. You probably could bring it back. Maybe that was the reason that there was some, you were saying that hemodynamics were slightly on the lower side. So, and also it definitely will prevent the hemolysis if you are going to leave it for some more time. So, but that said, I think I would have done exactly the same for the circumflex, and probably with or without imaging guidance, I think it's okay for the circumflex, but probably osteal circumflex, if anybody wants to look at it, I think it is not a bad idea to look under imaging, but angiographically it felt it is not involved at all, the osteal circumflex. And the provisional stent is my strategy as well. Yes. What do you do, Dr. Benson?
Yeah, I would go the same way. I would stent from left main into LAD and then do a pot, re-enter the circ, balloon dilate the struts, and then do a repot. That's what the EBC does currently.
Pulled the impeller a bit. I have Dr. Ashwini here with me for the impeller support. We pulled it a bit as you recommended. Now I'm taking in a balloon to balloon the ostium of the LAD. Yeah. See.
Do you often take a wire in the coronary, in the aortic sinus, or
I've
it's only
taken
for
it
this
only
case?
for this patient because of the osteal disease. I wanted a flotation wire to tell me where to place my stent. Yes, please.
Yeah. While you're inflating the left main, could you show us the hemodynamics on the impeller at the same time, please? And console.
Boost. So we had a temporary flat line. Use the boost. My pressures are now back.
Yeah, can you...
Now again have a pressure of 96.
Yeah. Can they show the hemodynamics on a different screen? Yeah, that's right. Okay. Show us the impeller, please, and on the console.
Can somebody show that? Are you able to see it now?
No, not yet.
Can somebody show the hemodynamics of the
Yeah, so...
impeller and of the screen both?
120 by 80. That's good.
Yeah. So can you pull back your impeller a little bit more? I think pull it back a little bit more. Oh, it's okay. Okay, that's good. Yeah. So that the angle of the impeller should be at the aortic valve, and that's much better. So earlier it was much deeper. Okay. So I think you were saying that you had bradycardia when you inflated, Dr. Sarita Rao, when you inflated left main?
Actually, one should be ideally operating in iliocranial or osteal left.
Should we go ahead with the stent now? So the length of the lesion which we estimated on the IVUS, it was the diameter, the plan is to take a 3 into 26. What do you say?
Yeah, that sounds good. Anyone else?
3 getting over inflated to 4.
No,
Would it be okay?
yeah, sorry. It wasn't the vessel size was 4.0, right?
4,
No, the vessel
4.14.
size was 3. Kayur?
No, the left main is
Yeah.
much roomier.
3
Yeah.
point?
No, so
At LED ostium, it was 3.2.
yeah.
Yes, the vessel size was 3.2 at LED ostium.
So you can take a 3.5, I guess. That may be a better choice because you have to do a pot and then you have to pot the LED, the left main again.
Yeah. So how much, in your opinion, Dr. Bansal, 3.0 can go up to what size?
No, there
Let's
are
pot.
stents which can go much up.
Yeah.
They can go up to 5 also. But,
All right. Yeah. So you shouldn't use 2.5 for sure because that will not go up to 4.0. So 3.0 can go up to 4.0. But Dr. Bansal's point is that maybe take a 3.5 and be gentle on the inflation and then take a pot with a larger balloon in the left main. But your choice, Dr. Sarita Rao. You're running the show there. So whatever makes you feel comfortable, we want to just suggest that anything more than 3.0 is fine.
Okay, so we are planning to go up with a 3.0. This is an onyx stent which I'm taking. It can go up to 5.5. It can go up to 4.5.
Good. That's true. And you also want to see basically in 2 views, caudal and also cranial to make sure you're in getting the left main ostium.
Yes, absolutely.
Right. So, sorry, we did lose you for a little bit. What happened when you inflated the balloon? You said something, patient became bradycardic or?
So the pressures, we had a flat line on the pressures. The
Right.
rate started decreasing.
Yeah.
I have a temporary pacemaker in for backup too.
Yeah, I think at that time, essentially the entire impeller was inside the ventricle. So what it was just doing is it was not giving you good hemodynamic support as we want it to be. So that's why pulling it back definitely will improve.
Yeah, I think that helped. The second thing is we took a boost at that time. The pressures came back pretty fast. Yes.
Actually, the point which you mentioned, Dr. Ramesh, is very relevant in this times of where you do crossover stenting. The differential expansion limits are written on the each stent pack. That should be kept in mind. What you mentioned is very right. 2.5 cannot go into up to too much high. 3.5 platforms are okay going up. Especially, I think Resolute Onyx has this left main now study, which has come up, Rolex study, which did a lot of work like this, and it can, the higher ones can go up to 5.6 is the limit.
Can I play
But
that?
I think at least you should be 3
Still I
because
need to push.
2.5, I think, I don't think it can be
Not in a
expanded.
healthy
That's
zone.
a very
Play-
critical point.
Play that view.
Other important thing is when placing a osteal, for sake of everybody here mentioning, the checking in elevocranial, what madam is doing is very important because caudal views which you are sometimes take may be deceptive. So bro, please check in epicranial and elevocranial, the osteal positionings of the left main, and that will give you a correct idea. Otherwise, sometimes you miss out.
Push.
Nonetheless, Srinivas, one would certainly like to see the eleocaudal also.
Yes.
Yeah, you can
Ready?
see
Or a
it,
AP
but
caudal.
final
Measure.
osteal placement, sir.
Yes,
sometimes
it has to be in
is
cranial. Yes, I agree. On
Caudal.
Caudal.
Center it, please. Okay. Looks good. So what is the funnel feel? Looks good?
Yeah, I think. So yeah, because of your sinus wire, it appears that the marker is exactly matching the sinus wire. That's a good
Yeah.
sign. If you want to go in LA or cranial one more time, I just want to make sure that.
Final once in an eleocranial.
Yeah, because there is a gap between in Resolute Onyx.
Fast.
There's a gap between the marker and the
fast.
stent. Yeah.
My pressures will drop. Okay, short.
Generally, if I'm sure
Yeah.
I
Go
have
back.
a sinus wire in, I can really
Caudal.
abut my stent to the guiding catheter.
Guiding
I'm
catheter,
pretty sure
right.
it will never get in.
Right, yeah. You can pull it back a little bit, Dr. Bansal is saying. Yeah, okay.
Yes. Yes.
When in doubt, no, you should err towards coming a little more proximally rather than missing
That's
the
good,
ostium.
yeah.
Yes.
That looks good, Dr. Sarita Rao.
Yeah, I'm okay.
Yeah.
Yes, deploy.
As you mentioned, Ramesh, this Zines
Give me a boost.
platform where the stent
Give me a
starts from
boost.
the marker is again advantage in placing ostium. Though
Yeah.
for the differential
Defill.
expansion, she's preferring the other thing.
Bottle. Pressure. Okay. Give me a boost. Give me some ephedrine.
Yeah, the
Dr.
cardiac
Vikas.
output is still good on the 2.8, I think, or 2.6. Can you make the impeller screen bigger than the fluoro? Switch the screens if possible.
I think she's just placed, she's just seeing that patient result is good. Are you
Okay,
there?
the pressures have picked up again.
Okay.
Pressures are now again okay. We had a transient drop at that time.
That's an important point what madam is taking when you're inflating stent in the left main. You have to be relatively quick. Though impeller support is there, many of us don't have the luxury of having impeller. So in doing such things, you have to be very quick, plan everything properly. If you inflate it longer, once that vicious circle, especially if patient has LV dysfunction, which it develops, then it will be a problem. So always make sure that you're quick, at the same time be effective. And go up to the right pressures also is important. And get the stent back and a balloon back and inflate in the ostium to flare it up is also important. That you should do it right away before you get the balloon out, because once you get it out, there could be some challenges in going in again. So it's better to do it all the steps straight before you get the balloon out. I think now pressure is stabilized.
Yeah, so yeah, once you have the impeller, the flows are good, 2.6, and there will be a loss of pulsatility.
Okay.
And when you inflate the left main, and so there will be a loss of pulsatility. But still the impeller is working.
Okay.
And as long as you have the outputs and a loss of pulsatility, you're okay. And it will become
so
almost like a flat line with a mean arterial pressure. And that is okay for a short period of time. You don't have to panic.
I think you need to do a pot.
Yeah, I think the left main area still looks less.
Yeah.
Madam, what I suggest is, because we overlap it in the two centers, probably you'll do pot and optimize the result there. And we'll go briefly to the other center, and after 20 minutes we'll come back to you so that we can see the rest of the work. Is it okay? Because sessions
Sure, definitely, Dr. Srinivas. Thank you so much.
Okay, madam. We'll come back to
We
you
will
in
do
20
that,
minutes.
okay?
Thank you.
Anil, you do
Connect
that.
us to...
So, welcome back.
Yeah, madam.
So, we went in with a 4 into 6. Can you go to the point that we, stopped live transmitting? So we went in it with a 4-6 for the pot, and we dilated the LED with a 3.5. Can you show that? Next, please. Down, down, go down, much down. Further down, please. Yes. Next, please. Just go next till we've after deployed the stent. Yes, so this is the point at which we stop. Next, please.
That's correct.
Recrossed into the circumflex. This is a 4-6 balloon. Dilated the left vein. Next, pulled it a little back, dilated the ostium portion. Next, please. Then we took in a 3.5 balloon, dilated the LAD. Next, next. Go fast.
Some shorter balloons, we have more shoulder.
Next. Yes, next, please. So this is the point we were at. Now we had to evaluate the ostium of the circumflex. It's flowing well, but we wanted to evaluate it. We were having some interference in our IBUS machine. So we took in the OCT. Next, please. Next. Yes. So this was the OCT run.
So
Stent was well opposed.
so this is OCT from the circumflex back? Or
No, from the LAD.
LAD back, okay.
That is the ostium of the circumflex. So it seemed to be okay. Now at this point, next please. No, minus please. Minus. So we were reasonably happy at this point. What do you say, Dr. Dagubati, Dr. Sandeep, Dr. Srinivas?
Yeah,
Everybody
so I mean,
from the
ideally,
panel?
if I want to assess the circumflex, I'd rather go into the circumflex and come back. But that said, we did not see any lesion angiographically before. So
Yes.
We did see some stent struts, I thought. So it may be worthwhile to rewire and at least, balloon dilate the stent struts,
Yeah.
so that they abut on the sides. Because it has been seen that if your stent struts are floating in the at the
Yes.
ostium of the circ, then the chances
Then you could
of
have a
rupture-
fenestrated restenosis later on.
Yes.
Yeah, bridge effect or something.
Yes, but ostium of the circ was looking a little.
I think
You
there
say
is.
we can take in a 2.5 balloon and just dilate that point at low pressure. Would that be okay? What do you think?
Yeah,
Yeah.
just to spread the struts across from ostium, you're saying.
Right.
But the
So-
word
Yes.
of caution generally is that the LCX ostium is a difficult animal to conquer. Once you do something, the patient tends to come back. So do it only if you feel it is absolutely essential. Here we did OCT,
Yes.
some struts you are seeing across, then maybe small low pressure inflation to separate the struts, you can do it. But don't be too much aggressive to work on
Yeah,
it.
so I make a final decision with the provisional. This is provisional.
Yeah.
And when to do a balloon for the ostial circumflex or a stent depends upon whether there is threatened dissection,
The result
less than
looks
TIMI
good.
2 flow, or more
For
than
the-
90% stenosis. Here,
For
this
the-
patient does not meet all the criteria. So I'm actually comfortable walking
Leaving
away, and in case if the patient comes back, will come back. But I don't think I'm forced to do anything.
Yeah, that's-
Because if you do a balloon, you have a dissection,
then there's a problem.
and then you're going to be treating either with a drug-eluting balloon or a stent. Or if you do, final kissing balloon was made a comment here in the audience on the panel. Yes, you can
Minus.
do. There is data to suggest that final kissing balloon is okay based on the COBIS-2 registry that we have. It's a registry. They looked at kissing balloon versus no
Minus.
kissing balloon, and it's not going to be adversely affecting. In fact, the TLR rates are better if you do final kissing balloon in provisional stent strategy. So, but still, as I said, it's a registry, so I don't buy it completely.
Ramesh, more than that ostium thing, left main, that stent at that point looked slightly less compared to LAD. You need more dilatation of the left main portion, bigger balloon.
Right. So, madam,
So
you
in this
used
scenario,
a-
is any FFR is helpful in this scenario for the circ compromise anything?
Sorry?
FFR is helpful in this scenario.
Yeah, FFR will
No,
come
minus.
negative definitely. Only question is whether you want to separate the struts from the ostium, that school of thought. Otherwise, as Ramesh said, it's not absolutely indicated. Unless you have threatened to do something, you may still get away by not doing FFR. We have seen many times it will come negative. Even if struts across, as flow is maintained, FFR will come negative. I did this in live transmission
So at
PCT
this
also. It was
point-
looking very tight, but FFR came negative. I think what we feel is left main, you have done part with what balloon, madam? Proximal optimization?
It was a 4x6.
Okay. OCT wise, how much
We
area you
went up
got
to
in the left
20.
main? How much
What was
area
the
you
OCT
got?
area, Raj? Can you tell me what was the OCT area? With the 4x6, we had gone up to 20 atmospheres pressure. And after listening to your discussion, and I think I agree with Dr. Dagubati and with the rest that, I
can leave
don't
it.
want to touch that circumflex.
Okay.
Yes, your point about left main, maybe I can go up with a 4.5. But let me just look at the area. Raj, can you tell me? Did you catch?
How much was the left main diameter measured on OCT
So
when you're doing?
on the OCT, it's 7.9.
Area, huh? Okay.
Yes.
Diameter, I think probably it'll take a little bigger balloon because it looks little less. And as we covered up to the ostium, there's worry of whether proximally dissect is not there. You can be little liberal and optimally sizing with a stent. Sometimes some people believe doing stunting only from the diseased area. There you have the worry that it would get dissected in the proximal portion. Here, as you covered right from the ostium, I think you can be little aggressive and take little bigger balloon also and dilate it well. Because LAD area looks bigger and then the left main area, even in the angiography wise, if not by OCT. OCT also, I felt the slightly left main area is still underexpanded. You can, I think, attempt taking one more bigger size balloon and do part of the left main.
Maybe 4, 5, you can do
So I'm
one.
only worried about one thing. My left main is exceedingly short. Now, the moment I take a 4.5 balloon, I might have a plaque shift and my circumflex ostium might get compromised.
No, here that
At
worry
this
is not
point-
there, madam, because you have covered up the ostium. You can keep the balloon a little outside of the ostium and position it distally. And if you don't have a short balloon, you can come back into the ostium, into the aorta, and then inflate it because you have anyway ostial stent is covered the left main ostium.
We'll go with your suggestion. We're taking a 4.56.
That's the problem of what madam is facing in the lab is many of the times you don't have a 6 mm short balloon. And even if 6 mm could sometimes become big for a very short left mains.
We have a 6 mm balloon.
Okay, ma'am, go ahead and do
So
that.
we are taking with the 4.56.
Yes.
What
The
is
good
this
thing
balloon?
about our lab is it's equipped with everything.
They're asking what is the balloon's name, madam? What is that 6 mm balloon? Termo company? Okay.
For AccuForce, I guess.
AccuForce Termo. Okay.
Yes.
Does it have a long shoulder beyond the distal marker?
Yeah, well, inflating it looked like it had.
Yeah.
I think it's just okay, no? It is looking proximal to the
That
L6
looks good,
origin also.
actually.
No
Give me a
problem.
small test.
I think you can go ahead.
Yeah.
Yeah.
Pulling. Yeah. Yeah, deflate. Deflate. Okay.
Yeah.
Bottle.
Yeah, I mean, if you want, you can go up to the carina. It's, but it'll-
Little more distal also, you can go up to Karana. That's what sir is telling. Yeah. So what is recommended generally is to be up to the proximal portion of the origin of LCX. Don't cross it because again plaque should be set. So proximal portion, if you do it, then it gets optimized there. I think that's what she tried to do. We'll see a final picture when you do a great job of demonstration of
Excellent.
complex case.
And are you planning to do the right this time, Dr. Sarita Rao, or next?
I think we planning to do the right. Patient is stable, comfortable.
Impella is there.
Yes, impella is there, so we might as well finish the procedure.
In fact, since it's an infarct-related artery, you might as well go ahead and check the viability in right, actually.
Yeah.
You may not need anything, absolutely.
Right.
Anyway, the data also shows that everything need not be done in one car. You can stage it also. But I will leave it to you, madam. I think once you show us the final picture, we would congratulate you and take from you.
Okay.
That looks better. It looks better compared to previous angiogram. Great demonstration, madam. Congratulations. I think you'll also check finally an OCT run also. And words of applause you can hear from all of us. Great demonstration of impella supported severe dysfunction patient post-infarct and with all care. And that demonstrates how good the PCI techniques are. In earlier era, I think I see my senior colleague, Dr. Rao, sitting. We are all doing, sending these patients in emergencies for surgery. Surgeons would also hate it, and it's not easy to do surgeries at this thing. And if at all some patient lands into problems of restenosis, that's again, patient can be tackled at a later stage. So I think that's a great advantage, especially with the support devices like Impella coming up. We can all do comfortably with keeping the patient's interest in view. Congratulations,
Yeah.
madam.
Thank you so much. And I would like to thank the panel for their excellent comments and the lovely discussions which we had. Thank you from all of us here at Indore. And with the advances in intervention cardiology, I think such procedures can now be well handled, which are surgical rejects, and we can give these patients a fresh lease of life. Thank you so much.
Thank you. Great. Congratulations.
Fantastic job. Thank
Fantastic.
you.